Hello everyone. Welcome to 渡米医師のキャリアレター Medicine Migration and Meaning へようこそ。
このポッドキャストでは、アメリカで消化器内科医として働くセラとマコが、日米で活躍する医師をゲストにお迎えし、臨床キャリアそして日常を等身大の視点でお届けします。ということで、今回はスペシャルゲストの、ニュージャージーで働くホスピタリストのチーナ先生をお迎えしています。Welcome, China.
Welcome!
Thank you. Hi.
So, for this podcast, we're going to have a conversation in English, and I think you'll be able to see the translator in YouTube. So feel free to take a look at it. But Mako, do you want to go ahead and give the
Sure.
introduction?
I would like to introduce Tina today. She completed Bachelor of Science in Respiratory Therapy and Chemistry. She worked as a respiratory therapist for 2 years after that and then joined med school. She graduated med school in 2019, started internal medicine residency, which she completed in 2023. And since then, she has been a hospitalist practicing in medicine in New Jersey and New York.
Oh my God!
Thank
Welcome,
you.
welcome, welcome.
Thank you.
So, me and Mako have been working with Gina in the same residency in New York. That was like one of our highlight in our like lives, that was so fun. And we've been always wanted to invite you and then, hear about your perspective because I feel like you're the one who is always like kind of thinking about your career and also like, trying to prioritize like what is important in your life which
Yeah.
I think is really important, but sometimes it might be so difficult. So I thought, that is something we wanted to learn from you. So again, thank you so much for joining us today.
I feel so honored to be here. When you texted me about it, I was like, oh, okay. Thank you so much for inviting me. This is so cool. Yeah, thank you. I'm delighted and I'm always happy to talk about the journey as women in medicine. It's difficult to you juggle life, be married, being a woman, and then also maybe having kids, not having kids, all of that stuff. When do you do it? When not? It's all just like things. So I'm happy to talk about it too. Thank
Right.
you. Yeah.
So just to give a background, can you tell me about like what you're doing right now and then also like the kids, like how old is she, blah blah blah.
So like you said, I graduated internal medicine residency with Sarah in 2023. Um and I immediately started working as a hospitalist. So that's mainly any patients that come into the emergency room and require admission for any kind of illnesses. I'm the primary physician that's seeing those patients. So I work mainly in the hospitals, primarily taking care of acutely ill patients. I initially started as an independent contractor, going to multiple different hospitals. It's called locums. And then now I work in the Bronx care system in New York, and I work as a attending physician, but also like a kind of like a faculty member. So I teach residents, but also still the same thing, all admitted patients that require, acute care level of care, but not quite ICU, like step down in acute care level of care. Then they come under our services and we work along with our consultants to, take care of them. So that's what I do right now. I'm also a mom, a new mom. So I have a less than 2 year old. She'll be two very soon. So, that keeps you very busy. So I juggle work. I'm full time. And I have a husband too. I'm also a wife. That's also a job. But
Mhm.
Very true.
It's a big job.
it's a big job. Yeah. So I'm also a wife, but I also have she's 23 months right now. Um, so yeah, she's so cute. Yeah. So that's, and we take care of that. And then we try to just, do the best you can with each role that you're playing and go from there. So that's what I do right now.
Should we
Yeah.
start with your job part of your
Oh, yeah. So yes, I wasn't sure where to go.
Yeah. So, as a hospitalist, what is
Yeah.
your schedule like? Like, when
Oh,
you are
yeah.
saying you
So
say it's a full-time job, what's that like?
what does that mean? So I guess I could start with just like in the full month as a hospitalist, I work 14 days full time out of the month. And then I get 14 days administrative. So I'm not off, but I'm doing more administrative duties. So the 14 days that I'm on the clinical schedule, I would start with, say, for example, I go back tomorrow, Monday, right? So Monday, my day starts at 6 a.m., meaning like that's when I am aiming to be in the hospital. It's like I leave the house by 5:30 a.m. I'm trying to be at work by 6. Sometimes I'm a little late, sometimes it's like 6:30, but I aim to be at work at 6 a.m. The reason why I go so early, because some physicians don't have to do, but the reason why I go so early is because I have to do prep work because I have residents that I have to oversee, right? So I have to also make sure that I know what's going on before I go see the residents. So 6 a.m. is kind of like my quiet time to prep, do what I need to do. And then I round with the residents from 7 a.m. till about 9, sometimes 10. We're rounding and also having teaching sessions. So like 7 to 8:30, it's we're kind of like discussing each patient that came in overnight or was there from before them being admitted, what's been done, what do we think we're going to do, and then we go see each patient individually. I have to assess how they're practicing physical examinations, all that stuff, but also make sure I'm saying it on my own, agreeing, disagreeing, things like that, rounding with everybody. Then I have what we call interdisciplinary meetings at like 9 a.m., where I'm rounding. The residents are still there, but then now you have the social workers, the nurses there. And also, they're looking to me to be like, hey, what's going on with each? And usually, I have an average of 20 to 25 patients sometimes during the winter times. If I'm lucky, it could be less than that. But like, usually because the winter time is really sick patients. So that's the hospital is always busy. So 20 to 25 patients. And each patient needs some kind of treatment, and you're just giving like, this is the treatment plan, this is what we're doing. So then at like 10 a.m., I finally have, that's when we're kind of done with that. Then I have time to like, okay, we did all of this. Let me sit back, and are we missing anything? I go back again and look at the patient's chart, look at everything on my own, check if there's something that I'm like, wait, is that what happened? I go back and talk to the patient. During this time, new patients are also coming, old patients are going. We're moving patients back and forth, and I'm dealing with that. There's also minor little procedures that we're doing too after 10 a.m. that you prep for, so that from like 10 to 12, you kind of try to do that before the lunchtime. So like, paracentesis that we are having to do, lumbar punctures, we do that too. Yeah. Like line placement, central line placement. If the nurses are not able to do it, I'm guiding the residents to do it because it's a step down unit. Sometimes I'm making sure chest tubes are placed properly, managing vent, like there's a lot of other procedures that I try to do after the initial rounds and things like that. Then you have documentation. That's the one that takes the longest time, right? So in between then I try to eat something, catch my breath, then I do documentation. And if I'm lucky, I'm heading out by 2, 3 o'clock to come, go because, daycare schools closes by 2 to 3. You're picking up your child, but it's not like I'm done with work. It's just like my on-site work is done. Then I pick up my daughter, try to spend some time with her, get her settled into her plaything, her afternoon session. Then I, call the residents again and I run the list with them, make sure what's been done, what's not been done, how's the patient faring after that procedure, who's gone, who's still there, why, what's going on with discharges. Because one of the biggest things a hospitalist job does is almost like you're directing traffic, meaning you're making sure that the right consultants is seeing the patient. Like, does this patient need GI? Does this patient need palm? Does this patient need cardiology? And after the consultants give their recommendation, you're also making sure you're kind of like the barrier of, oh, I know that that's the recommendation, but we have to remember that this patient, it's contraindicated because this patient also has this. So we can't do it. So you have to know the patients intimately. So, you're following up on that, running the list with the patients. And then throughout all of this, if there's an emergency, the residents are constantly in communication with me and all of that stuff. Then I have to prepare dinner to have dinner for the
Mm.
family right? Put closely down for bedtime. And then I review my cases again. And I try to be in bed by 9 p.m. And then it's a rinse and repeat kind of schedule. So that's how like my typical day looks like. I don't, maybe that's too much, but that's how my typical day looks like every day for just like clinical work. And then when I'm not doing clinical work, I'm catching up on administrative duties, arguing with insurance companies or not, filling out forms, paperwork that wasn't done when I was busy with clinical, catching up on that, and then having a lot of meetings, like teaching like didactic sessions with the residents also and things like that. Yeah, I'm trying to spend more time with the family because it's more of an easier schedule. And yeah. the-
It's simply cool. Like you guys are like managing like 20 and 25 patients. And then when I was listening what you're doing, like immediately I like reminded myself like being in the back room doing all the like, tasks as an internal
Yeah.
medicine resident. That was a lot.
It's
It was
insane.
truly a lot. How
Yeah.
many residents do you have in your team usually?
So yeah, so I have, let's see, I have to count it. So I have two seniors. So you know how like when we were residents, it was like split into team A. Like when you were like on the eighth floor, for example, one resident said no, they're all in one room, but they split the lists. So there's like an A side and a B side, but then I'm in charge of all of that unit, right? So I have two seniors, and then I have at least four interns. Right? Yeah, and I have one, like, floating intern, like, they kind of are there in case it's too much work for the rest of the residents, but it's usually a standard of 4 interns, 2 seniors, so 6 residents. Sometimes I could be blessed with 7 on a usual day, yeah. It's a
And you
lot, it's
it's a lot. You round with them all together, or you do, like, half and half,
I
or
do
how?
half and no, I can't do 6. It's 3 at because they all like the thing that I didn't appreciate when I was a resident is that when they're all looking to you for the answer, right? Because you remember when you're preparing to present to the attending, you have your specific questions that you want to ask the attending, right? That's your agenda. Oh, I don't know what to do. And you're waiting for the attending to also tell you what to do, right? And now now I'm the I'm the attending doing that now. I'm the attending that has to come up with the answers, and I'm gonna be very honest. Sometimes I don't know the answers, and sometimes like that's why I have to do prep work before I start because it's weird if the person is leading the team doesn't know what's going on. You need to know before you show up, right? Instead of relying on the residents to know, you need to know what's going on in the background so that you have the answers for them. And then you also want to, it's not fair to the residents not to have to teach because the whole point of them coming to residence is to learn. So you also want to be like, oh, what's a teaching moment here? That's mentally exhausting too. So it's a lot. And then imagine 6 and all of them, all residents, you guys usually pretty smart, very intelligent. So they would feedback, Doc, I don't know, according to this guideline, it says this. And you're like, yeah, but we have to think about the clinical scenario. And then you're like, like it's that dialogue versus when I was a hospitalist working as locums and not having residents, I was just by myself. First, at that point, one of the positives of locums is you have lesser patients. You get to, so when I was doing that, I used to cap at like 10, 15 patients by myself, but I was by myself. So I didn't have to like do prep work, then do rounding, then do my, like it was just, I just did it and the work was done. But when you have residents, you have to give them a chance to do it first. Then like there's a lot of redundancy. It was just me. I met the interdisciplinary team. We talked about it and that was it. It wasn't as complicated. I would say it was a little bit more straightforward. But the beauty of me working with a faculty group is that if I could leave when like once I've seen everybody, once everybody's stable, because there's a lull time and then you can go, okay, call me if there's anything. I'm gonna leave the campus and work from home to do the rest of the stuff. But I just have to make sure I'm available and I don't leave far away from the hospital in case I have to dash back. I could, so that reality is there. So that's the positive of it. Meanwhile, when I was a hospice locums, I have to stay for the entire 12 hours and, make sure because I'm the direct contact with the nurses. I'm the one, doing everything. But I've noticed that my day goes a little bit easier with the just staying for the 12 hours. There's no complications. I'm just doing what needs to be done versus when I have to wait for the residents to, communicate and like, oh, no, 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 I wish you didn't give the patient that med. But it's a learning process for everybody. I'm sure our attendings are just like, oh, this is redundancy. So it's a give and take. But yeah, it's a lot.
Yeah, I remember when I was like an intern or even a resident, the
Yeah.
attendings come in sometimes knowing what we're going to say, and they
Yeah.
just have to listen to our presentation
Yeah.
and correct our mistakes. And
Yeah.
that does seem very redundant,
Yeah.
but like
It's
we
the only way you
appreciate it
learn. Yeah.
because we need the education and we need someone to let us know that
Let us know what's going on. Yeah.
exactly.
But also like the residents are having to do the grunt work, for lack of a better word. It humbles you because you realize, oh God, I am so glad I'm no longer a resident. But by doing it, you learn. But you're having to go through the process of actually putting in the orders and making sure the orders are followed and like the annoying parts of the job. So that's what overwhelms, but it's just short period of time and then it gets better. So yeah. Yes. It's a give and take. It's weird. But yeah, that's me in a nutshell. I love hate. It's a love hate relationship, but it's more love than hate, I will be honest. Lately it's been more love than hate. So
And
that's
then when you're on, are you going to be responsible for the weekend as well, or like it's based on
yeah.
the day?
So that's why I said my schedule is 14 days. So literally I start Monday, March 2nd. I don't stop until Sunday at midnight, March 15th. Oh, and I should also probably say this, when I'm on for those 14 days, I'm on call. So if like a patient comes in at 2 a.m. that's not doing so well and they need like the residents don't know what to do about it, like they are worried that the patient is decompensating. I'm the one that they're gonna call to be like, hey, this is going on with the patient. And I have to make the decision of, okay, do I trust you enough to know that you can present what's going on and I can tell you exactly what to do? Or do I need to go into the hospital to review the case and see what's going on? 80% of the time, usually I'm just hopping on the computer, seeing their lab work, seeing their vital signs, and, explaining things to them in that way and going, oh, we can do this. Or I'm seeing all of that and going, hey, this patient needs to go to the ICU or call the intensive. The good thing is that we have a ICU doctor on call in the hospital that can go in and do what needs to be done. So that does happen in a way. But I'm the one. So like when I'm 14 days on, 14 days off, for those 14 days, 24 hours, I am in charge of that patient until they leave the hospital. Yeah.
Is that
So
the common way? I feel like
no,
in my residency there was a nocturnal
nocturnist, yeah,
hospitalist.
man, like, the hospital systems, which each hospital you go to, it's slightly different in the way things are run. So at this, because I am in a kinda like a community hospital right now, so there's no nocturnist on call, but there is an intensivist, and you could do the whole thing of like, "Hey, yeah, okay, if that patient is that sick that you have to call me at 2 a.m., just send them to the ICU." That's fine. So my particular hospital they don't have a nocturnist on call. So that patient's still under your name. And as long as they're under your name, they're your responsibility, period. But for example, when I was doing locums, that wasn't the common way. You're responsible for the patients. They're under your name only for 12 hours. while you're in the hospital. And once you're like, it's almost like a clock in, clock out where you're badging in, you're responsible. And when you badge out, you're signing out the patient to another physician who's going to work the rest of the 12 hours overnight. And then there's this weird hybrid, kind of like our residency, where um, you're still responsible for the patient, but you have a nocturnist that covers you while you're sleeping. And then, and then you're taking over and you're the primary care. So it's weird, but every hospital system has almost a slightly different way of how they staff physicians. And also, it's just availability. I mean, you guys know the Bronx. It's hard to get people to go to, you know, anyways, it's hard to get people to go to the Bronx. So it's harder for them to be able to staff that way. Also, it's a smaller community hospital compared to like where we train as a little bit bigger. So that's why it's like that. So, yeah.
I feel like you have seen like a lot of like different like practices. What were the like things that you wanted to make sure that they have or like versus like they don't have, like including those like nocturnal systems or
Oh, yeah. So man, like when I first graduated residency, I was almost like lost in a way because I was trying to figure out, I knew I didn't want to continue like with fellowship or anything. I knew that this is before my family life and what I just like the next stage in my life. I knew, okay, medical education, I think I've reached where my cap is as of now. Things could change 2 years from now, and that's okay. That's the beauty of life. You can mix and match and figure out. But I was just like, I'm at my limits end right now. But I didn't know what system I wanted. Every time I would go for a job interview was always different. And the pay was always, I was confused. So I needed to almost like take a minute to figure it out. So I started doing the locums gig. And I would say like the first time I did locums was a rude awakening of how I needed to navigate. There's a way to navigate the system. So I had to come up with it's almost like non-negotiables is what I call it. So like I had to come up with, if this hospital system doesn't have this, I think it's 4 things I had on my list, then I'm not gonna even step first. The first one was that they had to have a critical care doctor for 24 hours because I think it's because there's a lot of hospital systems that the hospitalists are considered the ICU doctors. Like there's a lot of hospital outside of the metropolitan area, which common thing to know if you're going to do locums, you are going to be outside of the metropolitan city area. You are going to be in like the middle of nowhere where they're more desperate for physicians in that area. So because as we trained and we did ICU rotations, we're technically trained for it. But I knew where my skills lied. And I was like, I want to have a hospital where there's a 24-hour critical care doctor that can do all the procedures I don't want to do, like the central lines, the intubations, all of that stuff. I'm not trained to do it. I don't want to risk doing it. I don't want to put that risk on my license or in the patient's life. So somebody who's trained, 24-hour critical care doctor has to be on it. My patient to physician ratio couldn't be no more than 14 since it's just me doing it. And if there's an emergency, and no more than 15, I'm sorry. If they're not willing, and it can't be, oh, we say 15 and then we're gonna change it and say we're too overwhelmed and change it to 20. No, it sounds selfish, but it's more of a safety thing with the patients too. So that was it. The EMR system had to make sense. Like I loved Epic, but I was willing to work, but it had to be an EMR system that worked no matter where I was. And like I can't be stuck to just one I needed to be able to move freely. You know what I mean? So that was another thing. And of course the money had to make sense. I don't work for free. So that's just we worked hard to get to where we are. So the pay had to be something that could still continue my lifestyle. So those are like my top 4. Oh, and sorry. And the 5th one, very, very important, malpractice insurance. Very important. We don't know about that when we're training, or the malpractice insurance has to make sense. So there's always different types of malpractice insurance, but it needed to cover me even after I've left that hospital. So like the tails end, because like we are in a system that's very litigious. So every little thing, not that I'm intentionally going to try to harm a patient or anything like that, but mistakes to occur. I'm human, and some patients might be upset about the outcome of the care, and it doesn't necessarily need to be like I was at fault or there's any fault to blame, but when there's you don't want them to come for your personal assets. So I needed to, and I couldn't at this point when I started, even up until now, I still can't afford my own personal malpractice insurance because that's millions of dollars that I would have to shell out. So the hospital had to be willing to pay for not just immediate malpractice, but till it's called tail's end, meaning when I left the system, they're still covering me. Yeah. So those were the top 5 things that when I would talk to an agent, I would ask them, and if it was a no for any one of them, and then I immediately went, "Thank you for the opportunity. Let me know when you find a system that has all 5 things." And that's kinda like how I went.
That's very good to know because I just underwent the same processes, like,
Yeah.
finding a new job as attending. But, I learned a lot of medicine during my fellowship, but, we don't learn a lot about those negotiations. Also, I did not know what were tables on the negotiations, right? Like,
Yeah.
I was only focused on the salary, but then there's a lot of like, practice models and then
Right, yeah,
malpractice,
yeah.
like, a
With a
lot of things. And
run
then,
so much. Yeah.
right. And I called you multiple times and then, asked
Right.
for advice. But I think, the negotiation part is not often sometimes that we do as a Japanese physician because there's no room for negotiations.
Uh,
And it's really hard how to have a conversation to like ask for negotiation. But I think that's really important. Like,
yeah, it's
you,
very important.
yeah,
I think it's not yeah, it's interesting because you mentioned that I have a question before I answer your question for me. When you're in Japan, do you just automatically just get posted to a place to work and you're like, that's your job. There you go. Is that how it kind of works? Even after training and all of that stuff? Or after training, do you then go find the job that you want to do?
I mean, actually, I've never,
Oh, that's good.
trained. I mean, I never worked there as attending. It's only kinda locum thing, and then, they set a, like, $60 per hour kind of thing, and then if you agree, then you, like, press, like, "I'll apply this job," and that kind of thing, so there was no room for negotiation. Not
Yeah.
I don't know about, like, as a full-time physicians, but I do believe most of the time, like, there's no room for.
I don't think there's a way to negotiate at least the salary part. And the malpractice insurance, from what I know, we join individually if we need to, and it's not super expensive compared
Oh,
to the
to the
US.
United States, yeah.
So, yes.
Okay.
So, I've never heard anyone actually negotiating with the hospital that they wanna work in order for them to find the good fit.
Fit.
Yeah.
Oh. So, I'll be honest, it's almost similar in the US when I first started the journey and I was listening to all this stuff. Like when I first started applying for full-time jobs after residency, I'd apply to these big hospitals and they would give me a number of how much they're willing to pay, and they just told you what you're gonna do. And usually what you're gonna do is kind of standard everywhere to a certain point of, okay, that makes sense. But the number they give you for the amount of work that's expected of you, I was just like, that's it? Really? I was like, okay, I get it that I'm not super subspecialized, but come on. I just could not fathom that that was it. Like, it just did not make sense for me. And I will say that maybe sometimes I could get a little arrogant, and I was like, "I'm better than this. I studied for 12 years of my life to get to this point. Like, it's not fair. And I have all these responsibilities, all these student loans to take care of. So I need to, and I'm not going to be making ends meet. No, like that doesn't seem fair." And so, and it's crazy when you say it in the United States, but like doctors make 3 figures, of course. But you have to think about like student loans and training and all of that stuff to get to where we are. And then also, depending on what practice you're in, malpractice insurance and keeping up with your board certifications, all that fees that come up, all those little tiny things. It's death by thousand minor cut. Your licensing, it's death by a thousand cuts. I'm not a naturally born millionaire, so I learned from a younger age. You have to ask. The most they will say is no, right? So that's my number one rule. At least I'm going to ask. If they say no, either I make the decision that I'm okay with the no and I'm still going to do the job, or I'm not okay with the no and this is just not an environment that works for me. So I'm rather suffer until I find something that works better for me. So it took me a while. I was behind the I remember my advisor used to freak out. She's like, Chino, you're not accepting any roles. What's going on? You're not gonna be able to immediately start work. Like the pressure to like follow the timeline, don't have gaps in your resume. And I was just like, look, I already have gaps from taking a break after college, working as a risk. I already am not the traditional black and white, follow the transparent path. So I'm okay with the gaps. I would rather take a break and find something that wouldn't cause me as much headache. I need to know what I'm walking into before I sign. And then it's like you have to sign this contract of like 2 years, 3 years, you're shackled, you're stuck. And I was like, I need a minute. But I think the biggest advice I can give with negotiating is two big things I would say. One, I learned later on, but one I think I kind of learned during the resident. One is know your worth. Just know you worked hard to get to where you so it's okay that you're deserving to ask for what you're because it's not like you're asking for crazy things. You're not asking for $1 million and then you only want to see 5 patients. That's not what you're asking for. You're asking for safe patient, physician to patient staffing that you know you're comfortable with. You're depending on what you're negotiating. That's one of the biggest thing for me. I'm asking for time to do documentation in the healthiest way. I'm asking for, yes, I know I went into this job to take care of people, but that's not gonna pay my bills. I need to be able to not be worried about finances, at least, because I'm still a mom. I still have to take care of my daughter. So I need to be able to afford to keep up with my lifestyle. So I'm asking that's so that I can focus on what's important with the patients when I'm at work. That way I'm not tempted to do unsafe practices like trying to get my RVU bonuses up and doing, so like when you understand the why behind what you're asking for, it gives you the confidence to know how to do the negotiations. So know your worth. You're worthy of what you're asking for. And then the second thing is be realistic with what you're asking for. Like I had to learn that. I think from all the things that I did and also talking to you and some other friends as we're negotiating. Because like I will be honest, when it comes to specialists, I'm like, you should be making $1 million, like but you trained so hard, you went to college, but now I've calmed down a little bit more and like you want to be realistic. So that means do your research, meaning like ask, thank God for Google, thank God for Bing, thank God for all the search engines and just talking, right? For like it's so annoying because our attendants, like the heads, don't want to tell the trainees the reality of what they earn. I don't know if it's an embarrassment or if it's just like, oh, don't tell anybody this is what you make, or I don't know, or maybe they signed a non-disclosure agreement, but it's not freely talked about. So you have to really do a lot of deep digging and push and ask, what's the average salary in the state that I'm in the system that I'm in? What's a realistic salary? And then always go, can I add more? Always add a little bit of a 10% I always do. It's just maybe I'm greedy, but whatever. I own it with pride and joy. And then, ask what does it like, okay, so I'm asking for a 15 patient cap. Is that realistic? In that hospital system, is it possible for them to even give that to me? Because there's some hospital systems that I walked into, and yes, they agree to the 15 patient cap, but when you walk in, you automatically just know, oh, there's no way. They're like, for example, where I am right now is 20. There's no way they can do that because of just lack of staffing. They just can't. They're trying, but they can't because somebody still has to. The patients still need to be taken care of. So no, realistically, in the state you're in the system you're in, what's a realistic negotiating window? And then come up with your best. I always when I went into the interview and stuff like that, I come up with my 3K best case scenario 3 times. So my best, my top number, if you give me this number, and if you agree to the other stuff, like, that's like best. I add on some more things like administrative days twice a week and like, paid time, like all these other paid time off is standard, but like, maternity leave that's not like add on to the 10 weeks expected, maybe make it 16 weeks of, like just all these other like nice cushy things that office jobs and tech people, and I'm being making assumptions, nice cushy things that maybe finance bros have that we don't have, like just see what I can like squeeze out. I always do that because the worst they can say is no. And then I ask for the middle ground, like, okay, I'm willing because I like the system, because you're giving me this, I'm willing to back off and do this. I'm willing to talk about this. I'm willing to do this, negotiate because you're going to give me a visa, because you're going to do this. I'm willing to do this. And then there's also have your standards, your non-negotiables, because then if you agree, I'm learning. If you don't, like, there has to be at least 5 things that you're like, I have to have, because your day to day gets difficult if those things are not just difficult, it gets impossible if those non-negotiables are not. Like, that's why it's like your non-negotiables are important. Where like you calculate your cost of living. How much will it take for me to save safely, pay my bills, do all of that stuff? And if it doesn't meet the quota for that, you calculate, okay, on average, it takes me this much to see a patient. You want me to see this many patients. Can I squeeze that out? If it's a no, then don't even bother. Don't try to, oh, maybe I can't. No, it's not healthy for you. Then that's what breeds burnout too. Then you get burnt out. You want to leave and all of that stuff. We still get burnt out regardless of what you do, but at least, and just you want to make sure you're non negotiables so that when because there's gonna come a time where you're 2 years into the job, everybody's forgotten about your contract, and they're like, "Oh, but Dr. Waba, you can just do this." And you're like, "Actually, no, because according to my contract, it's written in black and white. This is what I signed up for." So that is not part of my job description. So I'm not going to be doing that at this time. Now, if you want to renegotiate and I can consider whether or not I want to add that to my job description, that's a different conversation. But for you to just add that on me to do with the expectation that, oh, you're a team player, you don't mind doing this, that's not fair. So that's why you always wanna have those like and then when you walk in, you're not coming in all cowardly and arrogant. I'm bad. No, you're coming in with, I know what I'm worth. I know what you can offer, and this is what I'm willing to accept. And that way it's a conversation and then so that I think that's the healthiest thing I can say. But always negotiate because you never know what you're gonna get or not get. It's not fair to because not that I'm saying these corporations are big bad, but it's also not fair to you to just take the crumbs because you're not. No, we worked hard to be where we are, and we need to walk in that manner also.
A lot of great tips. And I think everything is coming from that, know your worth, which
Yeah,
is really important and strong message.
yeah,
Because, when you're applying med school or like residency, like we are really at like wanting to match there. So like we actually say, okay, I'm such a hard worker, like, really
yeah.
sell yourself. Yeah.
You
But it's
sell yourself.
completely gonna be the different world where like you have to like negotiate like what you want, what you need, etc. So that's a difficult part, but I think your all of your negotiations like priority come from like know your worth, so I
Yeah.
think that's really
Like,
important.
it's a mental health shift because, like, trust me, when I was trying to get into med school, it's like, "Please, please, please take my money. Please just give me the opportunity to show you that I can do this." when you're trying to get into residency. It's like, I know I don't look like the typical people that would do it, but please, please, please just give me an opportunity to show you what I can or can't do. Same with fellowship, my resume, all of that. But then once you've gotten all that training, once you've shown you've done the work, you've studied, you're bored, you've worked hard to get to where you can, and then you're still just like, oh, thank you so much for the opportunity. No, I mean, when does it end? When does that cycle end?
Overall, are you happy with your job, like lifestyle, in
I
terms
mean,
of everything?
we're being honest. I'm not gonna gloss it. I'm never the one to, me.
No.
I'm never gonna be like, oh yeah, this is amazing. I am loving it. And even after everything, I did the perfect thing. No, like I'll call it a love-hate relationship. So there's things that I love, like the actual medicine. I would be honest. There was a time when I didn't know if I loved it anymore or not, when I was so burnt out, and just the act of practicing was driving me insane. But I've come to realize I do love it. I do love being a hospitalist. I really do like taking care of the patients on the level that I do. I love that part of it. I do. I do like teaching. Talk a lot. So I do like the teaching aspect of working in a residency program and seeing young minds finally get it. And I'm like, oh, I do like that. I do hate the administrative duties that come with it, the paperwork, the having to negotiate on behalf of your patients. I do hate that. I'm having to be responsible for 25 patients. I do think that's a lot, but it's life and you do the best that you can with each one. I do hate the Medicare, Medicaid dance of it all. I hate the access that one group has access, another group doesn't have access. I hate the political aspect of the job. I do struggle with the mom guilt of our jobs take a lot of brain power and it takes a lot of time. And so, like the 14 days when I'm doing clinical work, it almost feels like, thank God I have a good partner that steps up, to help with her. But I do struggle because, like, the younger they are, you're trying to foster the bond, but you also are trying to provide and you're trying to keep your individual personality too. So I hate that push pull I feel when I'm working and my attention is not fully on her and wanting, because all I want to do is just play with her sometimes. I want to be here. I want to be with my daughter. But when I'm with her during my work times, there's a part of my brain that's also thinking about my cases and am I doing the right thing? Am I answering the right questions? Should I be consulting, not consulting? Like, so that disconnect is very clear. She almost can sometimes you can see that she knows mom, because she'll mimic me, and when I'm on the phone, she'll be like, "Hello, patient? Yes." So
That's so adorable.
she mimics me too. Or when I'm on the computer, she'll bring her little toy laptop and she's like, just like trying to. So I hate that she's seen that already at such a young age, but it's reality. So maybe we could show her, like I don't know. So there's the mom guilt of it too. But right now for where I'm at, I think I'm where I'm supposed to be. It's always tiny, right? I decided to leave the locums game and do the full-time mom game because I needed consistency at home once I realized I was pregnant and having a child. Like I needed the set scheduled time. I needed to be home by dinner time. I needed to maybe leave her bath. Just like it doesn't seem that important, but those are things I needed the flexibility of like, oh, my baby's sick. I need to go tend to her and I can just take out my sick days and not worry. So that's why I chose this current job and this current because once she's old enough and I don't have to be as consistent and once finance is a lot more stable and I don't need to get into the whole of like, oh, expect a paycheck every 2 weeks, then I can go back to the locums game of the independent contract work and go, oh, okay, so now I pick and choose where, because it's almost like you're traveling, you travel for a certain amount of, it's almost like locums is like travel physician. You go where the need is high, right? You go where the demand is. And okay, I can go for, and I will work hard for 3 months and just work, 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 do what needs to be done. And then I know at least I've earned enough that will last me the rest of the year. And maybe I'll still work here and there and stuff like that. But then the bulk of the time, I'm doing what needs to be done at home. But again, it's a very unpredictable schedule. So you just grab it when it comes to locum. So it's, there's almost an adrenaline high to it, I'll be honest, of like, "Oh, I'm working, great. Oh, man, I'm not. This is gamble. Is it gonna come or not?" But also the art of just, like, not having to deal with the political system of a full-time job is also beautiful for locums because with a full-time job, you're on in meetings a lot of times that you don't really feel like you would need to be in those meetings. You're responding to emails, you're caring about insurance reimbursement, but with the locums job, you're solely focused on clinical work, it feels like. When I was a locums, that's what it felt like. I'm zoned in on just, is this patient healthy? What do I need to do to get the patient healthy? And it's up to the hospital system to figure out how to give them those resources. But as a full-time physician, sometimes it's up to me to be creative with the social workers on how to meet the patient's needs. And that's the part that I really don't like. It takes away from the medicine of it. So yeah, that's
I really like to hear like you're being honest about like what you like about your job, what you don't like about, because so that you can reflect, to the like job search. Like maybe like in Japan, it is thought to be beauty, like to be stick in one company throughout your life, like not changing.
yeah.
But at the end, you want to be in a good place. You want to be happy and you can choose your own environment without complaining, but just searching like new jobs. So
Searching, yeah.
I think that's one really strong part you've been doing.
Yeah, I think again, it goes back to knowing your worth. And even after you've done everything and you get into this environment, a lot of people are afraid of change. So a lot of people are afraid of change. They're afraid of what is it gonna look like in the other employment? We always think the worst case scenarios. So it's like, God forbid I leave my current system and like no matter how like there a lot of people go, "Oh, I'm gonna oh my God, like I'm gonna actually like leave this mold that's here." This like they think this is the comfortable block, but is it? It's okay. It's almost like sometimes it's important, like journaling and stuff. Sometimes I would, because I would get, you have a really bad day. And sometimes that bad day is a bad week, and it's a bad month, and it's a bad year, and it's a bad 2 years. And at some point you have to just recognize that sometimes it's me, maybe I need to change my mindset and I need to change things, true, but sometimes it's not. It's okay to be like, wait, this is not for me, this is not where I'm gonna flourish. Because everybody always thinks, oh, you just need to work hard, work smart. No, sometimes that environment is not helping you do what you need to do, and it's okay to go, let me try to search for something better, and let me take the time to try to figure out where am I going to flourish and blossom. And it's okay that this is not working for me. So, and it might look to some employers that you're, changing hands frequently. Oh, you worked here for only a year, and then you're working here for 2 years, and then you're working here for 3 years. And the way to answer that during interviews is to say, I was finding my feet. I was finding what works best for me. I didn't want to stay in a place where I wasn't growing, I wasn't being challenged, I wasn't being educated. Because that's the truth. It's just the way it's not, oh, this person was annoying me, so I left. Because that's what you're saying, but it's deeper than that sometimes. So you find the most professional way to say it. Like, that environment, although the system works great from what I could tell, although that place I thought was gonna help me grow, but there were certain things I thought that maybe I could improve, and unfortunately, while I was there, I was unable to improve it, and our working relationship just didn't work well. I'm hoping in your system, and then I highlight what I thought was not working, what I thought could work better, and I go, "I hope your hospital system will give me an opportunity to see what I can do here and what I could make work," you know? And it's not like you're blowing smoke. Because again, you know your worth, you know what you're gonna do when you get there, you know? So that's knowing, again, it's almost like know your worth, but I keep saying it.
The important thing that we're learning from you right now is that you have the reasoning behind every decision that you're making and you're able to verbalize it. I believe that that's something that like we all have to learn to do, and like in order for us to say that we are worth this much and
Yeah,
that we're asking for a change because of this
this,
reason.
and this.
So I
Yeah,
really like it.
yeah. And I would be honest, day one when I was an intern, I didn't have this, you know, PGY. You, Sarah, can attest to this. I was kind of a little. Day one, this was not the way I was moving. Year two, I was in year three, first year out of being an attendant. I knew some of it, but I didn't have the language. But it took practice. You have to actually allow yourself to suffer a little bit. It took practice. It took sitting down and reflecting and writing and talking to ChatGPT and Gemini. Like, how do I say what I'm trying to say? Or just talking to other people, talking to like my mentors, like Dr. Shukla and Dr. Siao, because they were also hospitalists. That's where I was going to. And they really gave me conversations. And sometimes they would be like, China, that's unrealistic. Oh, maybe you can work that in. But if in order for you to be able to get to that level, you need to do ABC. They were able to bring me down and bring the realism, but also I took what they said and I also made it my own. So I didn't just follow blindly. Exactly. So everything I'm saying to anybody, don't just take it and go, okay, China did it, so I'm going to do it. No, you take it and you reflect and make it your own. Do your own independent, but yeah, it's true. It has to be intentional moves, intentional steps. It's not just, it looks to anybody outside not hearing what I'm saying, it looks almost like I've had people tell me that's so irresponsible. Mentors say that doesn't make any sense. I've had people say, you're not gonna be able to get that. It's impossible to. But now my salary is on the higher side for a hospitalist in New York. It's not like when people hear, they're like, "You're lying," and I show them my contract, and they're like, "Oh, how did you get that? Like, what did you do to?" Like, not bragging. It took a lot of work, but it's just the intentionality behind it. I mean, it's a lot. It's a lot of internal work, and it's a lot of mental work, but it's worth it when you get. And even when you do get it, I'm still constantly reflecting. Is this where I'm meant to be? Am I growing here? Am I learning? Is this in this space? It's like, I don't know. But you're right. It takes a lot of
A lot of learning.
a lot of learning. A lot, even after you're still learning. I think also I just want to say that I was required to learn this. Like, it's almost like nothing was given to me. Not a sad statement, but almost like a good thing that happened, because out of coal you make, out of pressure you make diamonds, right? So the no's that I got stimulated me to be like, oh, watch and learn, like almost like an arrogant challenge accepted. But yeah. What was your last question?
Challenges you face as, being minority, and then, how did you overcome?
Man, I think I'm still overcoming it. Yes, obviously I'm an African. I'm Nigerian by birth. Now I'm also American by naturalization, migration. I'm also an international, right? I wasn't born in the United States, but even if I was born in the United States, the color of my skin automatically puts me into a box. It's not real. It's like I grew up with my advisor in undergraduate telling me, oh, just bluntly, the color of your skin and your socioeconomic background is no way you're going to be a physician. Just bluntly telling me, just don't do it. Don't even do it.
Really?
Like, imagine I was what, 16, 17 when that was happening. Or so I ha- I took
Wait,
that.
was that in the US? Like you were told, like,
Yeah, this was in Alabama, University of Alabama at Birmingham. Yep, she was supposed to be my pre-med advisor, and so I had to, and it was a lot of like, I wasn't even allowed to apply.
That is
to
shocking.
med school. So it was like there was things like that. And it was like, oh, wait. And you find, but then again, that pressure of, I feel like I can do this. I know that I can do this. My parents telling me I could do this. My support system saying, no, this is not, don't listen to that, helped me, get to the point. And also just the internal turmoil, there's always this voice inside of you that would be like, no, you can do this. This is what you're supposed to do. And so finding that and again, knowing your worth from very little, knowing what you can do. That's the first start of the journey of discrimination. And then even in residency, the way patients will assume I'm the cleaner and something like that, or people that look like you should not be allowed to be doctors or something like that. I can't believe you're my doctor, and that's like a usual occurrence. But again, I meet it with humility and kindness and grace to a point where it's like, this is not, you're saying this, but I'm not going to receive it as that's what I am. I'm receiving it as you're just uneducated, you're untraveled, and you don't understand. So I will reflect more grace than you're giving me, and that will make me a better person than you. So it didn't, sometimes I'm petty, sometimes I'm mad, sometimes I come home and cry. Again, I'm not gonna try to be like, oh, and so, but whenever I'm able to allow myself to move in that, okay, bless your heart. The southern, would you like a different physician? Do you feel, do I, like, oh, I'm going to remove myself from this space right now. Or, sometimes I went the unhealthy route and I'm going to prove to you that I can do this, but then that wasn't healthy for me. So I had to pull back on that. And I just carried myself with grace and I'm still who I am. I'm still chill. I'm still nonchalant. I'm still me. So when I come home, I don't bring that home with me and I'm able to sleep better because it's a very, if you notice the discrimination and the challenges that we face, it feels like the end of the world in the moment. But once it's done, you grow from it sometimes. You're a better person, a stronger person from it a lot of times. And if you allow it, it almost makes it where you can come from a place of I might not understand, but at least I can reason and go, you just don't know. Your world doesn't allow you to see that there's a bigger world out there where you're naive, being naive is actually harming you. So like, at least, thank God my accent is American, which I say that, but I know with other IMG doctors, where, English is not your first language, but you still speak better English than most Americans or, things like that. And you're being discriminated against just because they're not taking the moment to pause and let you complete sentences or things like that. That working dynamic, it's a lot of first, don't let them take your worth from you. You know who you are. You know what you don't do. You know what your ability is too. And second is approaching with grace and just being aware that they're not at your level. So why even worry about what they're saying? Why come down and start going back and forth? Just go, I'm removing myself from the situation. That's a lot of the things that I've done. A lot of times I just like have a glass of wine with my husband and laugh about it or hang out with people that look at me and share stories and trauma bond about it to heal. I cry sometimes, but I think the most important thing is just like I continue to not let it change the DNA of who I am. So, you know, it has almost gotten there. I've had dark times where I question, why am I even doing this? This is like, why am I in this country? But I literally moved here when I was what, like 13 with my family. So I don't know any other country to start with. I can't imagine moving at an older age. It's even harder. So remembering the why helps too. And just knowing that this person is going to do this. But then 20 minutes later, another patient is going to go, doc, thank you. So it's all of that helps me go like the challenges, the discrimination. I think it's always gonna be there. I'm almost shocked when it's not. And I've just had to learn how to just smell the roses, blow out the candles, and just go, it's not you. It's you. It's not me. Because you know how it's me. It's not you. It's me. No, I know where I am. I know who I am inside. I know where I stand for. So I know my worth. So why am I going to let this minor situation? And if it's like a systemic issue, like a systemic discrimination, I just remove myself from the equation. Like that's why I'm not big on working with bigger hospitals these days. Like the bigger name, like I work in a small community hospitals where my coworkers look like me, my patients look like me, and I'm a little bit more comfortable in that environment. And so I'm allowed to flourish rather than going into an institution where I'm not necessarily even wanted. So I'm not trying to fight to get on that table anymore. Some people do and it works for them. That's not who that's not why I became a doctor. I didn't become a doctor to fight to be at a table. No, I'm already at the table. Whether or not you want to sit with me, that's your choice. So that's things that I do to make it work for me.
I feel like I became strong like after moving to the United States, and part of the reason is that I'm being like minority.
Yeah.
Like in Japan, I'm Japanese. Everybody's Japanese. Like I don't feel like any
Any different.
discrimination.
Exactly.
But here in the United States, I'm seen as like minority, like female, Asian. But again, there's a word that I did not like to hear from patients.
Yeah.
But, after all, like you set a boundaries. Okay, like that's their problem. That's not my problem. Like as you said. And then I think that is making me like strong, not to
Yeah.
keep that word in person.
In
So
a personal way. Yeah. No, I remember I have another friend, she's an African American doctor. She's a little bit ahead of me. I would call her in the bathroom and go, they just use the N word. We just supposed to just be okay with that. And I can't, and it's probably the difference is like for I remember Sarah with you would ask me, China, do you understand what I'm saying? Like my English. And I'm like, Sarah, you speak very well. This is not, it's alarming how diverse this country is, but still backwards in so many ways. But I'm sure you guys also relate to this, that you grow from it. So I try to don't get me wrong, these people need to be better. They need to behave better, they need to act better, we need to treat each other kinder. It's uncalled for the way that we're treated as minorities. It shouldn't even be a thing. I also hated being called a black doctor. I hate oh, that's the black doctor. Oh, that's the I'm just your doctor. That's it. Not black, not white. I'm just your doctor. So I hate it. I don't know why, but it's why I won't move to the South. But it's I don't know how to change them, so I only know how to react my way, and that breeds a stronger backbone. Like I think just kind of puffs me out a little bit. It's why when things happen, it's like, oh, okay, and then when we have our daughters and our kids, we can instill that sense of value in them too. Even if we don't do that, we don't have to. If we don't do that, at least for us, we know who we are. So we can walk around in the community knowing this is what I stand for, regardless of what everything else is. But yeah, I agree with you. It definitely breeds strength.
I think there's still like a lot of like hate among Japanese against like non-Japanese people. And I think that is coming from the fact that they don't know how diverse this the world is. So I sometimes kind of feel I wanted to drag them into like them into New York and then
I know.
feel like how it can become.
Yeah. Yeah, I think any world where you're not, where you're in your bubble and you don't burst your bubble or you're not curious enough to know what the other culture is like, it's always gonna be because the hate comes from lack of understanding. It's a lack of just like, "Oh, I didn't know you people could do that." And I'm like, "What do you mean you people?" Like but I think it's just you just go, it's not gonna stop me from traveling. It's not gonna stop me from enjoying the culture. It's not gonna stop me from eating the food because that's my experience, not yours. So this is how it has to go. Discrimination, I hate talking about it, but it's real and it's not a bear in green, it's a bear in figuring out how you react to those situations and what's the healthiest way. Maybe yours is not green. Maybe yours is not green. Maybe you gotta be petty because I do know some people that feel better when they're like, oh, okay, I'll shun and I'll make you wait to see me. But that's just not me. But you, whatever works for you, find it and just make sure you're growing from it. Yeah.
A lot of learning from you, Gina.
Oh,
A
thank you.
lot, a lot. I really remember, like, back in residency, there were a lot of diversity in our residence.
Oh man, yeah, it
And
was a
that
melting
was
pot.
great for me, especially because as coming from Japan, being a minority, like, I didn't know how to react first, but there were so many residents that are in the
Yeah,
same shoe, and that really
yeah,
helped me,
just get
understand
more
what I should be
comfortable.
feeling and how I should react to it, so and
Yeah,
as including you, Tina, I learned so
yeah.
much.
Oh, thank you, Marco. I miss working with you guys. It's just like residency is so stressful and it's so painful, but it's almost the most fun part of your training in a way. I don't know how it's just enjoy. Oh, I wish I enjoyed it a lot more and complained less.
What about you?
Yeah, no, yeah, it's toxic. It's dirty. It's a dirty, dirty game. You had to, but man, I mean, I think I felt the most at home. Like I don't know, maybe is it the New York City residency training that did that to us?
Could be,
It
could be.
could be because we were smack dab in the middle of Manhattan, or is it was we just lucky to have like a program that was so many international, so many people from different different ethnicity, Japanese, Korean, Africans, but not just Nigerian. You had Nigerian, Cameroonians, Ghanaians, and then you had the usual American, African American. It was like Latinas. It was very much a melting pot of what American reflects now. And that was something that I took for granted then.
We're so lucky.
Yeah.
I think we had a really good discussion.
Yeah. Thank you so much for having me. It was an honor and I hope
Yeah,
We
you'll
learned so
stay.
much from you, Tina,
Yeah.
today.
Thank you.
yeah.
Um,
Alright. では皆さん、今回は英語の編ということでお楽しみいただけたでしょうか。今回はホスピタリストのチーナ先生に来ていただきました。ではまた次回の、ポッドキャストお楽しみにください。ではありがとうございました。
ありがとうございました。
Thank
thank you.
you.
Bye.